Now I'm gonna introduce our speaker. It's really an honor to have Dr. Cooper join us today. He is the chair of the Department of Cardiovascular Medicine at Mayo Clinic in Florida. Dr. Cooper's clinical interest and research focus on clinical and translational studies of rare cardiomyopathies, myocarditis, and inflammatory cardiac and vascular diseases, such as giant cell myocarditis, cardiac sarcoidosis, eosinophilic myocarditis, and pericarditis. He has published over 130 original peer-reviewed papers, contributed to and editing books on myocarditis. He continues to work with clinicians and researchers around the world to improve the diagnosis, the treatment, and the care for patients with myocarditis and cardiomyopathies. He is board certified in heart failure and transplantation and vascular medicine. He's also the founder and former president of the Myocarditis Foundation and continues to serve on their board of directors. Simply put, Dr. Cooper is a world-renowned authority on the topic. I could not be more grateful to have him join us and teach us about myocarditis. I am certain by the end of this hour, we will all be better managing our patients with myocarditis. Leslie, the Zoom is yours.
Well, you're very, very kind. Thank you so much. I'm trying to share my slides, but I get a message that the host is disabled participant screen sharing. Is there could the host click to let me share?
I think Patrick's trying to feel powerful or something.
Well, while we're waiting for a moment, I just want to say it's super great to be with you guys. The one time a few years ago, I was able to come out and visit face to face. I really enjoyed it. And the only other time I was in Pensacola was actually for the United States Navy when I was doing officers training school a long, long time ago. And so a very different part of the city then. But I have spent the last 28 years studying myocarditis in various forms. Here we go. Screen one, share.
That looks good, Dr. Cooper. I'm sorry to interrupt, but just so you know, Zoom changed its rules where we had to have a waiting room. So someone asked to join the waiting room. I had to make you host to share your slides. So just
that's fine.
Maybe
I saw that somebody I had to click to let them in, and so I just clicked to let people in.
Yes, sir. They should all be good. I appreciate it. I'm sorry about that.
No trouble. Can everybody see the screen that says myocarditis?
Yep, looks great.
Great. Well, thanks, guys. So in this framework, I want this to be really interactive, and even though we're separated by several hundred miles here and it's virtual, I can see the chat, but it's not up all the time for me. So let me see waiting room. Admit. Sorry, I just had to admit a couple people in the background. I think
no problem. They're all legal. Admit all of them.
Yeah, I admitted all of them. Yeah, but now they keep showing up. So if they keep showing up, I'll be distracted if they keep showing up. But don't worry. We're going to go through this. What we're going to do is focus first on SARS-CoV-2 because it's really timely. We're going to do maybe 10, 12 slides and focusing both separately on the older people with comorbidities who are in the hospital, and then we'll focus on the young athletes, the Big Ten controversy, the Pac-12 controversy, and what the data are for canceling sports and sports participation risk. Then we'll go back into a kind of standard myocarditis talk, a little bit of epidemiology, make it clinically relevant, when you should clinically expect to see myocarditis, and move into some of the clinical trials that are ongoing worldwide. So we'll end up right on time at about 45 minutes. If you get bored or you want to go in another direction, just raise your hand and tell me. And intermittently, I will get these blue dots that say admit somebody, and you'll see me look in another direction and stop talking. So this is the topic, myocarditis in the era of COVID-19. And so here's the challenge. My slides won't advance anymore. Oh, there we go. Now they're working again. No disclosures, CME talk. Nobody's paying me for this or anything related to this. And then let's go back to the middle of August. So you probably all remember, especially if you follow any sports teams, that right about August 10th, the news came out on ESPN and elsewhere that the Big Ten had canceled this season. Now, of course, there's a limited season that's come back, but at the time, this decision was made based upon the risk of possible SARS-CoV-2 myocarditis in young athletes. And there was a paper that came out on the about 2 weeks before this, on the 27th of July, in JAMA Cardiology, from Valentina Putman and colleagues in Frankfurt, that said that about 78% of people who had recovered clinically from SARS-CoV-2 myocarditis actually had abnormalities on the MRI that could be myocarditis or other forms of cardiac injury. And nobody knew what this meant clinically. We still don't know, but it certainly spooked a lot of people, even though the rate of sudden death in all athletes is about 1 in 100,000 in that range. The range of you are actively exercising in the setting of a cardiovirulent virus could be a lot higher, maybe 1 in 1,000. And that's where it gets into the range where a university like Ohio State or Notre Dame would have reluctance about letting all of their athletes play if they had any kind of ongoing myocarditis. Those event rates would be too high. So that led to inconsistent but widespread cancellation of teams. This is a slide of an electron scanning micrograph of a cardiac myocyte in Rochester, Minnesota, which is infected with SARS-CoV-2. And all those little round balls on the myocyte are virus particles that are being, they're coming out of the cell. And this is one example. Others at Cedars-Sinai have published similar images, which show that you can infect cardiac myocytes, you can infect macrophages in the heart, you can infect other cardiac cells, and that can lead to some cardiac dysfunction. But we don't know the mechanisms, and we don't know how frequently this happens. It may be a fairly uncommon event. But based upon the principle that it could happen, lots of people are getting admitted here. We're going to go over the mechanisms. We're going to say, what do we know about the mechanisms, the timing? How is this new virus different than the typical Coxsackie virus that we've known about for 70 years? And how should this influence our recommendations for family members and universities for sports participation? Yeah, you know, it's kind of interesting. There we go. After so I let somebody in, my computer screen freezes. So you'll see there's a way around it I figured out. This is a slide that shows from Peter Liu, published in Circulation earlier this year, that shows some relevant points about the time course of SARS-CoV-2 infection. This is a typical situation where somebody gets exposed, they start shedding viruses before they're symptomatic, and then they hear about day 7, they get symptoms, then they get respiratory insufficiency, and then they end up on a ventilator or ECMO, and then pass away. But in this paradigm, and what they were seeing and are still seeing, is the viruses are actually shed from before you're symptomatic all the way through the end. And that's a very long window, right? That's 3-4 weeks. It's much longer than what you were seeing with enteroviruses that are cleared pretty quickly. But that in this situation, the cardiac injury is pretty late. It occurs here toward day 14, day 21, where you get troponin rises. It's certainly a very bad prognostic marker, but it's occurring not as an initial event, but as a consequence of what is maybe a systemic immune response and inflammatory reaction. And this is where you get the cytokine storm. And certainly throughout this whole episode, there's abnormal immune function, there's dysregulation, but is that dysregulation causing what we would call typical myocarditis? And it's unclear. There we go. So you can see this is another slide from the Wuhan experience, again, showing pretty late in the game here, survivors at the top, non-survivors at the bottom, that it is the cardiac injury, which is occurring here around day 14 or so, toward the end of someone's hospital stay. This is a study of older patients with pre-existing atherosclerosis or hypertension or diabetes. And in this group, I think that's very true. My experience in the hospital service would say that this is the kind of people who are on multiple inotropes, who are getting vasopressors, who have demand ischemia. They have a lot of microvascular thrombosis, perhaps. And this is the group where maybe some of them get myocarditis, but this is different than the younger athletes. And we're going to make that distinction that the younger people, the students, kids, have a very low event rate. But when they do get sick, they can get myocarditis. The kids can get this Kawasaki's-like syndrome, and they have about a 14% rate of coronary aneurysms. So there's this subgroup, a small subgroup of the younger people who do get viral myocarditis. And then you end up with the larger population of cardiac injury patients who are old with comorbidities who have this paradigm. And this we published in April, showing viral myocarditis way over here on the right as one of multiple mechanisms of injury in patients who had acute SARS-CoV-2 cardiac injury. We emphasize that clinically, it's hard to tell a cytokine storm from stress-induced cardiomyopathy, but some of these people will have ST segment MIs, a small percentage. Some will have demand ischemia with arrhythmias. A number of them will be hypotensive in shock. And there is generally not an indication for a biopsy unless it looks like this is something atypical and you are getting an unexplained cardiomyopathy. Maybe you're in the cath lab anyway, and then you've got to, then if you have the opportunity to biopsy or they're meeting other standard criteria for biopsy and happen to have SARS-CoV-2, then proceed on. There we go. So this figure, also from the same circulation paper, just summarizes the spectrum of illness that you see. On the far left, there's the ST segment elevation cardiac MI. We've all seen that. People still get heart attacks, right? And this is somewhat prothrombotic state. And this isn't all that common, but when it does happen, it's important to recognize that often the kind of injury pattern you see on the EKG has reciprocal changes. The injury pattern you see with myopericarditis or the more stress-induced injuries tends to not have the reciprocal changes, but sometimes it can be hard to tell. Here you can see in the non-obstructive coronary patients, myocarditis, cytokine dysregulation, and the stress cardiomyopathy being all factors. And these other phenotypes, it is important to realize that there is a guideline to give a prophylactic dose, low molecular weight heparin or apixaban, depends on your site. There's a clinical trial ongoing right now in Italy looking at the dosing of anticoagulation based upon the level of D-dimer. That trial is still ongoing, it's still enrolling, but at some levels we do recommend giving full dose anticoagulation. And then how does this happen? Well, we really don't know specifically because nobody has studied coronavirus in the heart the way enteroviruses, Coxsackie viruses have been studied extensively. In this, we do know from this study 11 years ago in the original SARS experience that about 35% of those people who died from SARS had viral genomes in the heart. And that when they did standard immunostaining, the macrophages were increased. Now, what's the relationship there? Was this a macrophage infection that led to some kind of myocardial damage? But we don't know. This was, again, 11 years ago. We do know from the current experience illustrated here in this autopsy series that you do get myocarditis, but it's not a huge myocarditis. Like in this series of 10 patients who underwent autopsy having died from SARS-CoV-2, lymphocytic myocarditis was present in 6 cases, but it was mainly epicardial and pretty mild. And the mechanism of death was probably different than this. So it certainly happens. It does happen, but is it a therapeutic target? When is it clinically meaningful? Now, again, this was a study, again, older patients, people with comorbidities in the hospital. We move forward here to a different population. And here is a young guy. This is one of the first case reports that came out in April of patients with, a patient from France, Paris, with a 33-year-old guy with chest pain, came in with elevated troponin, had a cardiac MRI. You can see here with the arrows, had epicardial delayed enhancement on the right there, which is typical for viral myocarditis. And he got better. He got better like most people do with this kind of presentation. But it shows that this is a different population. This is not hemodynamically significant. but it is myocarditis, not biopsy proven, mind you. At Mayo, my colleague Jay Schneider has been studying inducible pluripotent stem cells and infecting them with the SARS-CoV-2 M protein. And this slide, which shows in blue the nuclei, in red the cardiac myocytes, and in green the SARS-CoV-2 M protein, infecting on the far right in the merged image the cells. This establishes that you can infect these cells. They are clinically, we have at least one patient we've studied, maybe in the next slide here. Yeah, this is a woman who passed away with presumably arrhythmic death, had myocarditis, fairly impressive myocarditis. And we showed the SARS-M protein right here inside the cardiac myocytes, as well as the nucleocapsid protein. Of course, the inflammatory cells here in blue with the green where my arrow is were also involved, but you could infect multiple cells within the heart. So it does happen. That was a young woman, very sad, mother of two, died suddenly after getting SARS-CoV-2. So these are isolated cases, but they do happen. It's important to recognize them. Like other viruses, even influenza, bad influenza can certainly give you a fairly fulminant myocarditis. And this is no different. Occasionally you'll get it, and it's important to recognize it. Now, what does it mean for young athletes? We're now making the transition from the older population we talked about for a few minutes now to the kids, the younger people. This is a paper from China showing that in 26 patients who recovered from COVID-19, and they had previously been symptomatic, 58% had some abnormal MRI findings. And that included edema with the T2 weighted imaging, as well as some late gadolinium enhancement, less commonly. Now, there were some other functional parameters that were abnormal, and it's unclear whether these people had LV dysfunction from the virus or from other causes. But it gave us the first report back in May that at least there was a potential for later abnormal MRI findings in young people, in people who had SARS-CoV-2. This is a symptomatic population. This is not the young 19-year-old college student yet. But it raised the question of what happens in other populations. So the Valentina Puntman paper, as I said, 71 days after symptoms, when everybody was asymptomatic, had a 78% rate of abnormal MRI findings. Not all of it was myocarditis, probably, but and only of that 78, a third of those people had been hospitalized. Average age was 49 years. So again, hardly the young college athlete population, but a pretty high number. This is now moving into the kids and the pediatric population. A paper looking at Kawasaki's-like disease, which, as we know now, affects a small number of young adults as well as kids. And in this population, a fair minority have myocarditis, and a 14% had coronary aneurysms, which I doubt are going to completely resolve. So you could have, again, a proof of principle that some people are going to have long-term cardiovascular consequences from the acute SARS-CoV-2 infection. This is the Puntman paper that's gotten so much press in Wall Street Journal and ESPN and elsewhere that I just mentioned. Again, we don't know if this is all myocarditis, and we don't know the clinical significance. And then I'm going to skip this. This is just a paper, old paper 9 years ago in other forms of viral myocarditis in Germany, showing that about half had some diastolic dysfunction and a few had symptoms. And that abnormal relaxation was thought to be out of proportion to age and other risk factors and attributable to myocarditis. But just a older paper that just suggests that it's possible to have a late consequence with stiffened LV from acute myocarditis. So the paper that came out since I put this talk together is from Ohio State, and that was their young population that came out in JAMA Cardiology on September 11th. You may have seen it. They had about a 15% rate of myocarditis on their MRIs. Most were male. I think 4 of the people who were positive with myocarditis were all males. And just so you know, most myocarditis is worse in males than in females. This is a recommendation currently from the National Federation of State High School Associations, and I'm getting distracted. 2 people are in the waiting room, but they have not there. I think everybody's been admitted. Sorry, got distracted. This is the recommendation for what to do if you have a young person with SARS-CoV-2. On the right side, if they're asymptomatic, don't do competitive sports for 14 days and then resume. If you're symptomatic, it depends on how sick you are. If you're very mildly ill, maybe a screening EKG and a good listen to their heart, they're probably going to do fine going back gradually. But if they actually had myocarditis, say they had elevated troponin and chest pain, you should follow the standard guidelines, which are wait a minimum of 3 months before returning to competitive sports. We have no data that it's any better than enteroviruses, and so that seems pretty reasonable in the absence of prospective data. And then the role of MRI is really not known, right? I've done MRIs in this setting. They've actually been pretty normal in the people I've tested who are asymptomatic, but not a lot. And if you do an MRI, it's important just to realize that the clinical significance of the abnormal imaging findings is not yet known. Now we're going to make the transition to the last, we're about 20 minutes into the talk, halfway through. In the last 20 minutes, we're going to do a general myocarditis presentation. Before I go into this, I'm just going to look up here and see, you know what's interesting? I don't have chat anymore. Hang on, let me see if I can. So if any, oh, here we go, chat. That didn't work. Well, if anyone is trying to
Cooper, this is Lori Rice. If people want to submit a question in chat, I'd be happy to read it to you if you'd like.
Please, yeah, because the way I'm looking here, I don't see where I'm looking right now. I just don't see chat appearing, and when I click on Alt H for chat, it doesn't give me a chat screen. So just read it. Read it. If somebody wants to chat, we'll chat. So the last 20 minutes are going to be focused on general myocarditis. This is our first of 3 epidemiology slides, and this comes from the 2017 Global Burden of Disease study we published, or I was a part of, that was published in The Lancet in November of 2018. At that point, for the global study, we combined myocarditis and other forms of cardiomyopathy because in a global level, you can't distinguish them. There's no real heart biopsy or MRI in most of parts of Asia or sub-Saharan Africa, and so we put them together. And there were 343,000 deaths, and this is done by hospital ICD-9 code or ICD-10 code dismissal. Most of them, 200,000, were in males in blue, you can see on the left, and about 143,000 in women. And the rate of death was about 5.5 in men per 100,000, and about 4.5 in women over the past 25 years. And we just finished the 2019 paper, which has not, in fact, the comments are due October 13th. We just got them back. That's going to come out in JACC in the next couple months. And this is very similar data. The proportion of myocarditis, which we report separately in that paper, is about 25% of all cardiomyopathy. And the death rates are very similar to what you see here. I would say that the rate in men is slowly coming down, and we don't know why. Here's the US. So globally, death rates, I said, was about 5.5 globally. And in the US, it's a little higher. It's about 9, higher than average. Canada is lower, Japan is lower, Eastern Europe, USSR is higher. But the range is very different. If you look up in our area, there's Pensacola down here, and Louisiana, and Alabama, and Mississippi. They're pretty high rates here, up to 30 per 100,000 in various sub-areas here. But the lowest rates are actually up here in the upper Midwest, Montana, and actually Seattle has one of the lowest rates. So there are 4 ways that myocarditis presents. The best, if you're going to have myocarditis, you want to present with chest pain. Chest pain with a normal EF has the best survival, less than a 1% per year event rate, even in young men. I'll show you those data. But sudden death, which is quite rare, is devastating. And that does happen if you get somebody who survives sudden death, who has a cardiomyopathy thought to be myocarditis or of unknown cause, with sustained or symptomatic ventricular arrhythmias. That's a class 1 indication for a heart biopsy to rule out giant cell or eosinophilic. And then there are the cardiomyopathies, presenting with heart failure, and the driver behind death or transplant rates in acute and chronic cardiomyopathy is ejection fraction. The worse your heart function, the greater the likelihood of death or transplant in the final two. We study them because we can study LV recovery as a secondary endpoint, and famously, Coxsackie virus causes acute and chronic heart failure. But that is not the most common way viruses present in the heart. The most common way is chest pain with myopericarditis. Here's typical EKG that's pretty unimpressive. Just a little bit of ST segment elevation in a few leads, maybe over the next 3 days. You have a pattern of T-wave inversion, pretty diffuse T-wave inversion that would then recover. The reason I show this is because it's unimpressive. That most EKGs don't look very impressive, and you've got two things to look for: high degree heart block and QRS width greater than 120 milliseconds. If you get enough myocarditis to widen your QRS, in both studies from Europe and Japan, and for that matter from the Brigham, US as well, every study shows widened QRS has worse outcome. This is what it looks like on an MRI, and when you feel pain, inflammation, you can imagine this epicarditis and chest pain in a typical pattern that's worse if you lay on your back, better if you lean forward. This is what we treat with colchicine, and now there are multiple trials, one of which is rilanicin. Hopefully we'll be getting going from Conexa. This is what for chronic recurrent myocarditis we've used anakinra for. The rate of detection is going up. I like to say, if you give a man a hammer, the world looks like a nail. But if you give a man an MRI, you're going to diagnose myocarditis. And here you can see the rate of myocarditis as a fraction of all MRIs in Europe. This was presented a year ago or 2 years ago now at ESC. And the number here, first when we introduced the Lake Louise criteria back in 2009, and then in 2018 here we have the revised Lake Louise criteria. A lot of papers on T1 and T2 mapping for the diagnosis of myocarditis came out in this window, and a lot of diagnosis. I show it just to give a sense that there's a heightened awareness and a heightened rate of diagnosis in at least centers that have MRIs, I think. The criteria has evolved over the years. We wrote the first consensus document on MRI criteria to diagnose myocarditis in JACC about 11 years ago. And that was called the Lake Louise criteria because that's where the first meeting was outside of Calgary. And then the writing group. And then the second group, which didn't have the luxury of meeting in such a beautiful place, was just called the revised Lake Louise criteria. And that showed that if you combine both T1 and T2 weighted imaging, either with images or with native mapping techniques, that you end up with about a 90+% rate of sensitivity and specificity if you do it within the first 2 to 4 weeks. The rate of improvement is pretty fast. You can see here a couple data from a jar, and there are other data out there showing that it takes 2 to 4 weeks for a lot of the imaging features to improve. So you may find patterns of delayed enhancement or scar down the road, but and they may be typical of myocarditis, but they wouldn't be typical of acute myocarditis. The acute features often fade. So what's the prognostic value of MRI? Should you do MRI? When should you do an MRI? It's expensive and maybe insurance won't cover it. Well, there are a number of times. Our current recommendations, mine meaning also the European guidelines from Caforio and others, would say that in the younger population who have no hemodynamic compromise, it can be useful for prognosis. Here's an example. This is an Italian study, young men, 62% EF, good follow-up, very few events, 26 out of 374 had any cardiac event. And almost all the events occurred in people who had this anteroseptal pattern. You can see this delayed enhancement that goes right down the anteroseptum. That's the bad actor up here with a fairly high composite event rate. The other ones, no delayed enhancement or the typical infraposterior, 1% per year or less. So it's good for, the baseline is good for prognosis, I think, and to think of other causes like sarcoid. Then the Brigham series added to this. This is the Granny series. A lot of people with myocarditis suspected, 670. And this is more real world, 52% chest pain, 30% heart failure-like symptoms, 20% with some arrhythmias. And I would say that it's much more representative of what I see in a general cardiology population. And again, mostly male. Every study is mostly male, except maybe the lupus series. And about 13% had the bad EKG marker for outcome. And what they found, which was not unique to this paper or original, was that the presence of delayed enhancement was associated with a much higher rate of events, here illustrated on the right. And these were hard events, death or transplant. But the next study was, the next page, this is what they also showed, which was the original, and why it got in JACC, was that the value of MRI was actually in the, here in the preserved EF group. The difference in event rates was 0.4 versus 1.2 if you had preserved EF above 40%. And it was much higher and driven by your heart failure syndrome, and not different with or without MRI in the low EF group. And that's pretty much consistent with what we've recommended, that it's the healthier people who are stable, who can have no rhythm problems, who can lie on a table for 45 minutes, and hold their breath, who can get the MRIs. And there you do see a meaningful impact. What about biopsy? When should you do a biopsy? Well, biopsy is not dead. We still recommend biopsies, but we do so when it's going to change outcome. For 100 years, 150 years, we've used histologic criteria like this, but there's a lot of sampling error, variation interpretation, low sensitivity. Instead, Bernard Maisch and colleagues almost 30 years ago came up with immunohistologic criteria, which are still used in the European scientific statement and elsewhere, involving CD3 and CD68 positive cells, illustrated here on the left and in the center. And if you get more than 14 of these per high-powered field, there's an association with worse outcome, particularly in chronic cardiomyopathy. This is the Japanese data, but there are similar data from Germany as well. Notice on the x-axis, 10 years. It took a decade to show the difference in survival. This is a chronic problem. This is not your fulminant, inotrope-dependent, VAD or ECMO approaching patient. This is somebody who's months out on heart failure meds, not doing so well, gets a biopsy, has a scant infiltrate that's immunostain positive, and then you do see this difference. Now, what we don't know, although there are some data, is that if you treat these people with azathioprine prednisone, as has been advocated, in the absence of viral infection, are you going to have a better outcome? It's a great question. There's one case control study, I think I have the data here, that would say yes, but it takes 8 years to show a difference. That's a lot of immunosuppression. I think we do need a randomized trial, because the long-term trial has not been done. What about the fulminants? So that goes to what you do, when to do a biopsy. We're going to go make this transition now for the next 5 slides into when should you do a heart biopsy. And this is our scientific statement from the American Heart Association that came out in January. I was the co-chair, and Rob was the chair. And this basically says, think about cardiogenic shock and the young person who comes in with suspected myocarditis. And if they start requiring inotropes, biopsy early. And why? So this is from that paper basically saying, look for the low voltage due to myocardial edema. It's interestingly reversible. Look for pericarditis, and then if there is pericarditis, be sure to get a troponin. Troponin is usually elevated in that first week, but it can be normal later on. And think of a normal sized ventricle, because it has not had time to dilate, that may be slightly thickened because of edema. In this population, if they require inotropes, you can see in red that, the population that did not, that was healthy, the young guys with the chest pain who did not have any hemodynamic compromise, had a 0% event rate out to 8 years there. But the people who required inotropes, this is acute myocarditis, had a 35% rate of death or transplant, and 28% of that occurred in the first month. So it's an important phenotype. It's one that you should recognize. Inotrope dependence is a bad finding. Not many patients. It's a minority, to be sure. In my population, it might be 10, 15%. But if you do get that group, you want to remember to biopsy, because you're looking for giant cell myocarditis, as we'll see. And by the way, the last, even you think it's very rare, the last biopsy-proven case of giant cell myocarditis at the Mayo Clinic was 90 minutes ago. 90 minutes ago was the slides, I just read them with our cardiac pathologist. She was biopsied last night. So it does happen. Now, this is the current algorithm that you can see from the Boskert scientific statement I authored with her. And this is also in the Brunwald chapter and a lot of other places we've copied it, showing that you should do the biopsy if you need mechanical circulatory support or inotropes, Mobitz type 2 or higher secondary heart block, sustained or symptomatic VT, or if you're getting worse in a couple weeks. As we all know, when you treat people in the hospital, they tend to get better. We give them diuresis, we give them afterload reduction, and after a few days, they're perking up and they're walking and eating. If a week or two later, their EF has gone from 40 to 25, that's a very bad sign, and you do want to proceed with biopsy. Doesn't happen very often. This is the outcome with giant cell myocarditis, showing an 89% rate of death or transplant overall, and that included the people who recovered on immunosuppression. With no immunosuppression, the rate of death or transplant was 100%. And that's much worse than the lymphocytic myocarditis control group we published a number of years ago. The current guidelines on heart block and VT actually came from this study when we looked at the predictors of giant cell myocarditis, and these were the 4 criteria that we derived from that New England Journal paper. 29% of the screened subjects who we screened over 5 years for the GCM prospective trial actually had giant cell myocarditis. Now, there's a bit of a bias because this was Mayo Clinic in Rochester and our tertiary care centers that were trying to find this disease, and we were very actively searching. I think that in a more community-based population, that rate would be lower, but it's still pretty high. Hopkins published their results, and it was 20% or 21% were positive for GCM or something else in this clinical setting. So there have been other papers, again, supporting this concept from single centers elsewhere. So it's now part of the guidelines because it improves. Giant cell myocarditis improves with immunosuppressive therapy. This is a biopsy from a woman who was in our trial a number of years ago in Rochester, showing a very fulminant giant cell on the left, completely resolving at day 30 biopsy on the right. The patient today is getting OKT3, cyclosporin, and solumedrol. This is the similar data that came out of Rina Gandelin's series from Finland. It's the other large giant cell series. This was a group of people, all of whom received prednisone, usually with cyclosporin and possibly azathioprine. And their overall survival was about 70% at 5 years. Ours was 90% at 5 years with transplant-free survival. In their group of about 50, and in our group was about 77%. But again, showing that compared to 0% in all previous case studies up until 1995, there was substantially improved survival in the setting of multi-drug immunosuppression. So that's a weird, obviously a weird rare disease. 1% of myocarditis on biopsy is due to giant cell. What about all the rest, the big universe of myocarditis? Well, we know that from the myocarditis treatment trial that we do not have a immunologic intervention that changes outcome. This was prednisone with azathioprine or cyclosporin, 111 patients randomized. over 5 years, and they showed no change in either survival, transplant-free survival, or ejection fraction. And interestingly, in this study, higher anti-heart antibodies, IgG antibodies, and higher levels of certain inflammatory cell types were associated with actually better ejection fractions, suggesting that in some people that inflammation is a good thing and you shouldn't inhibit it. So what do the guidelines say? We do not recommend immunosuppression for most people with myocarditis. If you have, this is from the Heart Rhythm Society, HAACC, VT, VF guideline, says if you have unstable heart rhythms, get to a center with appropriate support for transplant, advanced arrhythmia management, VADs. And if you have giant cell myocarditis and you get over the acute phase and it's expected you'll live a year or more, an ICD is recommended. You don't need it right away in the hospital, but once they're stable. What about the other bad actors? In the last 5 minutes, I just want to cover these. The first is eosinophilic. This is a review of the world's literature by a young cardiologist who's now in San Diego, I believe, was in Milan at the time, showing that in the red curve, hypersensitivity myocarditis, which is often related to drug reactions, is very bad. There's about a 50% rate of either death, transplant, or bad placement in that population in Italy. I guess this is the world. There's a global, not just Italian series. It tends to be perivascular, eosinophil rich, not much necrosis, but there is a high rate of thrombosis. And if you look at the different individual reports, and I won't share you all these, but if you look at clozapine, or other hypersensitivity myocarditis, like or the drug reactions to checkpoint inhibitors, there's similarly a 25 to 50% rate of major adverse event rates. Most of these occur within the first 8 weeks of treatment. Here's just one slide on the clozapine. Myocarditis occurs in 1 in 1,000, 25% fatality rate. And with that, I want to just summarize a little bit where we are in myocarditis. There are trials ongoing, both in Europe. In France, there's an anakinra trial, which is an anti-IL-1 receptor antagonist for acute myocarditis. 120 people are being enrolled. That is most of the way through. It can finish next summer. There's a trial in sarcoid of prednisone, standard dose with the taper over 6 months, versus low-dose prednisone with methotrexate. David Burney in Ottawa runs that. It's going on at a bunch of Canadian sites, Virginia Commonwealth University and the University of Michigan. We've got mechanistic trials up using abatacept, which is an anti-CTLA-4 monoclonal antibody in New York for rheumatoid arthritis-associated myocarditis. And there are upcoming trials that are aimed at modifying the gut microbiome in Europe, and CBD oil in Canada. So I'm happy to discuss any of those and what's going on, or the guideline-directed management of cardiomyopathy or arrhythmias in the context of myocarditis. Thank you so much.
Thank you very much. That was great, Dr. Cooper. I'm going to start with the...
Are you back to the... Yeah, we're off sharing screen. Good. Okay. Great.
Okay. Can you hear me?
Yes.
Okay. So the first question about COVID patients, as you mentioned, if you're sick, positive enzymes, chances are you have cardiac involvement, and patients with COVID and cardiac involvement, the consequences could be delayed. Do you have currently any protocol to bring those who survive and do well, even when they have good echo while in the hospital, for later evaluation if they had positive enzymes or acute course requiring mechanical ventilation, or you just rely on the initial echo that looks good?
Yeah, so the scenario is, this is the hospitalized, perhaps older patient with comorbidities, has a high troponin, but they have no wall motion abnormalities. And then they recover, and they're clinically doing well, and their troponins have normalized. What do you do in the long run? Well, there isn't really a guideline for that. I personally would get an MRI when they're nice and stable a couple weeks later and can comfortably lie down. That would be to define whether this looked more like a Takotsubo stress cardiomyopathy, troponin leak, or ischemia with endocardial lesions, or epicardial damage from myocarditis. I would have done that to understand the mechanism of the injury, but I can't tell you that it would that would impact treatment.
Thank you. The second question is, you mentioned in patients with acute myocarditis requiring inotrope, biopsy may be helpful in case of giant cell myocarditis.
Yes.
Can make a difference. And you mentioned that immunosuppressants have no value or improving survival in other kind of idiopathic myocarditis. So in places where biopsy is not readily available and the patient comes in with myocarditis picture requiring inotrope, is there any harm of starting empiric immunosuppressant therapy on those patients awaiting biopsy, or would that screw up the results of the biopsy?
Yeah, that's a great question. So if you've got somebody who's in that slow crash, starting solumetrol is probably fine. What you're going to lose immediately are the eosinophils, right, from the biopsy. So the first cells to go are EOs. Then about 2 weeks later, you lose the giant cells. And finally, at about 4 weeks, you'll just get small foci of lymphocytic infiltrate. So they're the last ones to go. And the whole thing takes about 4 weeks to resolve. We published that about 12 years ago in a series of papers. So for giant cell myocarditis. So the only thing you're going to really mess up is the eosinophil count. And so I don't think that's a big deal. I think I personally have been, in fact, for the patient who's in the hospital now, we gave her steroids before the biopsy yesterday for a day, and it's probably a good idea. So yes, I've done that. There is no guideline. It's not in any of our chapters, but it's something that we do because there's not much harm.
Thank you. If anybody else has any question, you can type it in the chat section, or you can unmute yourself.
Yeah.
And ask Dr. Cooper.
I didn't go into the treatment, by the way, of eosinophilic myocarditis. Of course, if it's drug related, you withdraw the offending drug and give corticosteroids. Checkpoint inhibitor myocarditis is really important. It's growing, I would say, in my consultative practice. That's something I would see much more commonly than anthracycline cardiotoxicity nowadays. And there if there is evidence of acute myocardial damage in the first 4 to 8 weeks of therapy, you stop the drug, give corticosteroids, and there's a possible trial of abatacept getting started which would directly block some of those checkpoint inhibitor effects. So I didn't mention that in talk, but checkpoint inhibitors are really important. And I didn't mention genetics either. We could do, if anyone's interested, we could talk about genetics.
Well, looks like
yeah.
Questions somebody else has. So the role of
everybody, if you don't have my email, cooper.leslie@mayo.edu. If you have any questions, just send me an email. My cell phone's 507-301-9656. If you forget that, or you forgot your pen, you can just email me and I'll send it to you. And if you're stuck on a Friday night and you're in the ER and you got a bad myocarditis, you can just send me an email or a text and I will promise to answer you.
That's wonderful. That's really great. The other question I have about the role of life vest in patients with acute myocarditis, and as you mentioned, the risk of sudden death, the highest early on in the course. So how to time that, and what groups or subgroups of patients with acute, subacute, or chronic myocarditis would you consider life vest for?
That's such a good question. Yeah. So, there's the standard guidelines about low EF. So if you end up with somebody with an EF of 25, particularly if they have a lot of ectopy, I think that's a reasonable approach for a life vest. Now, many of those people, perhaps most, will actually improve to the point where they wouldn't meet criteria for ICD. So you want to use LifeVest in that population to let them recover, and then aggressively up-titrate your heart failure meds. But what about the others? So what if you have an EF, so you know, it's a little bit better, say it's 40, 45, but you're having runs of non-sustained ventricular tachycardia, maybe they're not symptomatic, and you're dialing up your beta blockers. I actually use a LifeVest in that setting as well. I do not use a LifeVest in people who have no delayed enhancement or a positive prognostic delayed enhancement, like an epicardial infraposterior pattern. In that group, you know, even if they're feeling some palpitations, I know the event rate is very low overall, and they'd have to demonstrate, maybe I'll give them a 3-week event monitor, but unless they're clinically having arrhythmias, if it's just on monitor, I wouldn't think they would need a LifeVest. The usual, normal myocarditis, no LifeVest.
Thank you.
So Dr. Cooper, there's 2 comments or questions that have come in on the chat function asking, does Mayo use strain imaging to help diagnosis before going to MRI or biopsy?
Great question. So yes, as one of the authors on the last 2 strain papers on echo strain for myocarditis, I can say we do strain. It's mostly useful, in my opinion, in normal EF people with suspected myocarditis, where I think you're going to have a better likelihood of clinically correlating with myocarditis than a standard echo without strain. But I would not, if I'm going to go to an MRI, it's going to be based upon a pretty high pretest probability, and the goal of the MRI is to use delayed enhancement patterns to predict future event rates. So I'm not going to stop at the strain because of strain. I imagine if it was totally normal, you might stop, but I haven't done that myself. I go on to MRI because I want to use the patterns. What about biopsy? It's very simple. Except there's some unusual circumstances, right? For example, Plaquenil associated cardiomyopathy. There is one where you can't tell it from lupus myocarditis sometimes, and you might need a biopsy there with electron microscopy. That's a weird one. What about, there's some odd times when Fabry's, in a woman, you might not be able to use leukocyte esterase because it's X chromosome linked, and you might need Sudan black on a biopsy. There are a few really odd ones like that I biopsy, but they're definitely outliers. Biopsy for me, 90% of my biopsies are in the native heart meet the criteria I showed you. Inotrope dependence acutely, VT or sustained VT with symptoms, or heart block, or they're going down despite doing the normal good stuff. And of course, there's always sarcoid. There's the occasional sarcoid where you cannot get any extra cardiac tissue, and you just don't know what it is. And there you do EP guided biopsy. Okay, that's the biopsy question in a nutshell.
One other question that's out there is, please comment on atrial involvement in myocarditis.
Oh, thank you. I'm so happy you asked that question. That's, yeah, we have a bunch of papers on atrial myocarditis. So there's a lot. We could spend the last 4 minutes just on atria. This is the deal. So, of course, the circulation paper 4 years ago showing that atrial giant cell myocarditis has a pretty good prognosis was a late career highlight for me. I was pleased we got that out. Joe Malachewski and the group in Rochester led that with a bunch of cases, some of which were my patients. But yes, atrial giant cell does exist, as does atrial granulomatous myocarditis, but they're pretty rare. Now, the more common thing is sarcoid, right? So there's a substantial minority of sarcoids that can affect the atria in isolation. And then, there's occasional systemic syndromic atrial inflammatory diseases. I'm not getting into the whole argument about inflammation causing atrial fibrillation or vice versa, which I think is a very interesting area, or the idea that you could give prednisone to lower the risk of atrial fibrillation. I think those are intriguing, but I think that's a separate issue. from acute or fulminant, well, really acute myocarditis in the atria. But yes, I'm so glad you asked that question. Thank you.
Okay, I have a question. Is there any insight regarding the reason behind the different prognosis in patients with delayed enhancement in the anteroseptal area versus the lateral? I mean, that's interesting. That's significant.
Yeah, so the Italian paper showed that they had lower inflammatory markers. It was more, the anteroseptal group was possibly a non-inflammatory, maybe later phase or more severe phase with scar, maybe instead of acute edema. And I wrote the editorial for that paper actually, and the patients came from Northern Italy, and I said, well, what if you just had a lot of people with desmosomal protein abnormalities? Could this be arrhythmogenic left ventricular cardiomyopathy masquerading as acute myocarditis? And so that was 3 years ago, and now there's a whole series of papers have come out looking at the relationship of acute or recurrent myocarditis with desmosomal protein abnormalities, both in families and in these larger series. If you look in Circ this year, 2 or 3 papers on desmoplakin in that setting, same the European Heart Journal. So my answer is yes. I think this is more of a non-inflammatory and partly genetic cardiomyopathy that is arrhythmogenic, right? And that's why you get the event rates. But that's actually just 2 days ago, we submitted the next Grunwald chapter and wrote a whole page. We had to delete a page on Chagas disease. But we put in a whole page on arrhythmogenic myocarditis, cardiomyopathy. It'll be coming out next year.
Thank you very much.
Yeah. Well, it's so nice to talk to everyone. Thanks so much for the invitation. And I'm happy to come back anytime. Right if you have any questions.
That's so wonderful. We really appreciate that. Has been great. And I really thank everybody for joining us and looking forward for the future lectures. Thanks a lot.
Yeah.
Have a great
Take
day.
care. Bye-bye. Stay safe.